Hello, everybody. Thanks for joining us. While we wait for everybody to log in, just to let you know, we are recording the session. So if you could just make sure your mics and your cameras remain switched off.
I don't think anyone's joined us yet. Waiting in lobby. There we go.
Hello, everybody.
Good afternoon.
Thank you for joining us. We're just going to wait a couple of seconds to leave everybody in from the lobby. Just to remind you that we are recording the session. And please keep your mics and your cameras switched off throughout the session. My colleague Kiwi is busy in the background monitoring the chat function. If you have any questions, if you'd like to post it in the chat, and we'll pick that up at the end.
Yeah, any resources we mention or any events, Kiwi will keep track of that and keep track of the questions as well for the Q&A at the end.
So the subject for today's webinar is empowering transition from bed to chair. We're going to look at the clinical side of things and the practical demonstration using a couple of case studies to introduce our new chair, the Air Comfort. We'll go into that in a little bit more detail as we move through the presentation. But if I leave Rebecca,
thank you,
wander off to load her side of the presentation. Just to remind you again that, we are recording the session. Please keep your cameras and your mics switched off. We will follow up with an email with a link to a copy of the presentation if you want to share that with friends. So without any further ado, I'll pass you over to Rebecca, and I'll be with you in about half an hour or so just to look at the new chair that we have with the case studies. Okay, thank you.
Thank you, Les. Just going to get the presentation up. I think everyone has joined us now. I think we're still kind of letting everyone in from the lobby. But as Les said, we will be sharing the presentation and in the PDF format, but also a copy of the recording as well for you to refer to or to pass on. I think everyone's joined us now, and hopefully you can all see the presentation. Before we do get started, I just wanted to quickly really highlight other aspects of our educational programme. So if you feel there's a particular gap in your knowledge, or you simply just want a refresher into the world of specialist seating, then hopefully we have a suitable face-to-face event for you that can complement these live webinars that we do every month, along with all the other resources that we share. Our full day workshops are now underway for 2025, and we've loved visiting all the different regions of the UK. We still have a few of these events scheduled for the rest of the year. The next one's being in Brighton and then Maidstone, and we're working our way up towards Scotland and Glasgow and then working our way back down again. So if we are visiting a location close to you, then please just reach out to us, register, because we'd love to see you there. The workshops came from, I guess, us feeling our responsibility and wanted to play our part in empowering you with the confidence to be able to advocate on behalf of the individuals that you support. So the whole point of this more interactive workshop is a full training day, but it's an interactive workshop to equip you with both the theoretical knowledge, but also the practical skills around assessment techniques and outcome measures, etc., to be able to achieve those objectives to, raise awareness and play our proactive role within postural care. We also have our lunch and learn sessions as well, which are held then at a location of your choice and are more bespoke to you and your team's learning objectives. So we will provide the refreshments and your local seating assessor will pop along with the CareFlex range to work with you over a couple of hours to identify chairs that are suitable for those specific conditions and postural challenges and presentations that you see within your area of specialty. Sharing insights into postural care and best practices around the chair, the setup, and then ongoing use as well. So please do get in touch if that's something you feel would be beneficial to you and your team if you have those specific learning needs. Now let's get started on today's webinar, Beyond Standard Seating, Empowering the Transition from Bed to Chair. In this session, we'll be exploring a critical topic really in health and social care that presents these unique and complex challenges that individuals who are confined to bed for extended periods of time face. So hopefully we'll uncover how prolonged immobility impacts the body, the mind, and also the recovery process. You'll learn how specialist seating, when it's introduced thoughtfully, can transform clinical outcomes, from reducing things like pressure injuries to enhancing physiological function, but also supporting emotional well-being as well. Seating is more than just a comfort tool. It's a therapeutic intervention, a class 1 medical device, and it's an important part of an individual's management and treatment plan. And then we'll have a look, as Les has mentioned, at our new chair to the range, the Air Comfort Deluxe chair. We'll apply the theory that we learn over the next half an hour to some practical case studies, and hopefully you will gain insights into those innovative features and the practical application that is designed really to bridge the gap between bed rest and mobility, to really support that safe transition, but in a comfortable, safe, and clinically meaningful way. Now, lying for prolonged periods of time in limited positions significantly increases the risk of body shape distortion and other significant secondary complications. Individuals with movement difficulties or those with complex needs tend to adopt certain positions in lying and in sitting for prolonged periods of time, and it's that combination of spending longer in one position, the asymmetrical movement patterns that come with that, and the effects of gravitational forces that leads to this high risk of destructive postural changes. Prolonged bed rest or being confined to bed presents a significant clinical challenge, and we sadly get this vicious cycle happening. Physically, it results in rapid muscle atrophy. We can get weakness, soft tissue shortening. We can see increased risk of pressure injuries because of those increased interface pressures for prolonged periods of time. And sadly, inevitably, the pain and discomfort that comes with that. Those changes can influence mobility, and it can complicate any attempts at recovery and rehabilitation. But the effects aren't just limited to the body structure. Dependency can increase on caregivers as individuals lose the ability to manage basic tasks potentially. We can see a functional decline with individuals becoming dependent on others, and we have this self-reinforcing cycle that leads to further immobility and greater reliance on caregivers. And then, of course, the emotional and social consequences too. And individuals often report these feelings of isolation and low mood and a diminished sense of self-worth when we see this confinement to bed. And as we go through the session, hopefully you'll see how these are all linked, and how they each then have a devastating effect on one another if we don't try and break this cycle. The musculoskeletal system endures much of the strain from poor postural habits, and we can see chronic misalignment, placing uneven stress on bones and joints and muscles. And of course, this then leads into pain and sometimes an increased risk of injury. So as such, comfort or lack of it is a defining aspect of person-centered care, and gives us a good indication of that overall quality of life and actually the level of care that we are providing as well. And I found this fantastic quote from Hippocrates, who was believed to be the father of medicine, and it's something that kind of reminds us of why we do what we do, to recognise avoidable suffering as a source of harm, and it just means that we kind of put that emphasis on the individual, so to cure sometimes, to relieve often, but to comfort always. And it's always good to be reminded of that. And things with comfort as well, it's completely subjective, so we have to find a way to communicate with the individual on how they might display that they are comfortable or not? Is it, especially the non-verbal as well, is there a particular gesture or sign or vocalization that they use that can let you know whether they are happy with that prescription or whether actually they're in a lot of discomfort? There's also this systemic impact as well, with prolonged immobility affecting virtually almost every major physiological system. Within just a few days of bed rest, we can see cardiovascular deconditioning happening. So we can see this heightened risk of postural hypertension or orthostatic intolerance. That can make changes to positioning, so standing or sitting more difficult and dangerous without careful consideration. The respiratory system, when lying flat, tends to put increased effort on the system, and it becomes less efficient, especially with individuals who maybe already have some respiratory distress, things like increased mucus retention, not be able to clear those secretions. And we can, of course, with that, see an increased risk of significant illnesses like pneumonia, particularly in the frail or neurologically impaired individuals. We've also got the GI system, so the gastrointestinal and renal systems as well. We can see the functioning slowing, we can see constipation. This can in turn affect appetite and nutrition, which we know is important to recovery. Urinary retention as well can become more likely, and we can see this contributing to infection risk and discomfort. So all those cumulative effects underline why transitioning from lying to upright positioning, even if that's partially with some compromise, is critical for maintaining that systemic health and preventing these significant associated complications. So research has shown that this inability to maintain an upright sitting position is associated with a decline in health, and this primarily reflected in physiological dysfunction. So as I said, we can see things like recurrent infections, constipation, choking incidents, cardiac inefficiency, which in turn increases the risk of illness and hospital admissions. So it's always good to find out in terms of their past medical history and their general health, asking those questions, you know, what is your health like usually, and hopefully that'll spark a conversation about actually, you know, they've had repeated chest infections or they've been in hospital for a severe illness, and then you can start getting true understanding of systemically what's happening there. Lung compliance decreases, airway resistance increases. So that's talking about how well the lungs can expand and how much breath we can take in, but also the functional residual volume as well can be impacted in lying compared to seated postures. Unsupported postures can increase the risk of aspiration, as we know, but also choking as well, especially if swallow is becoming difficult to initiate. Even in the general population in a lying position, when we talk about safe eating and drinking, but if you think about individuals who also have dysphagia, we may need to get support from speech and language therapy colleagues and team members to support us with those risk and eating and drinking plans. So what happens, especially in lying positions, which is why it's critical to come upright for sitting, the airway may not be well protected, and we can see food and fluid then entering the lungs, which puts us back into that vicious cycle of ill health and secondary complications that come with that. I mentioned about orthostatic intolerance or postural hypertension, which can be observed in individuals recovering from extended bed rest, particularly older adults or those who have been unwell. And any kind of prolonged inactivity or immobilization can cause the heart and blood vessels to become less efficient at responding well to changes in posture. And what we can see then is this drop in blood pressure upon change in posture, with dizziness or lightheadedness, blurred vision, and even fainting. So we need to consider the falls risks that comes with that, making sure we have safe transfers. But ultimately, it's about that sit-in tolerance and making sure that we allow for a progressive upright reconditioning. So thinking about graded seated strategies by utilising functions such as tilt in space or back angle recline. And with any postural intervention, we'd be looking at a gradual, gentle introduction anyway, so the individuals can adopt and be compliant with that new piece of equipment or that new position that they might just simply not be used to. And then we can see pressure injuries and tissue breakdown, and probably one of the most common and preventable complications that we see related to prolonged bed rest. And in this, I mean, of course, we can go into a lot more detail around pressure care, and there are going to be different categories and different stages and different reasons. But in the simplest of terms, posture and pressure are inextricably linked, because the way that we hold ourselves or position our body segments is, of course, going to have an impact on the pressure going through that specific body site. So when sustained pressure happens, it can impact on the local blood flow, so the cells don't get the nutrients and the oxygen that they need, and then we can see cell death happening. In terms of high risk areas, tends to be bony prominences, not always, but tends to be because of the lack of protection from fatty tissue between the bone and the skin surface. So things like the sacrum, the ischial tuberosities, the heels, and even the greater trochanterus on the side. If somebody's in sideline, for example, on the side of the hips. And we can see this in immobile individuals who spend hours in static postures without regular repositioning. So when we talk about pressure care, it's not about achieving this one gold standard position. You know, when you hear of this 90-90-90 sitting position, it's actually about a regular change of position. That's been shown to be the most effective method for preventing skin damage, about this regular change of position. What we want to do is obviously think of the care planning around that and how we input that into that 24-hour approach, but also the caregivers as well, and how we keep them compliant and consistent and confident with that approach. Now, mobility and activity are consistently identified as one of the top predictors of pressure injury development. And sadly, those of you who work with the older person or within elderly care, they're actually 5 times as likely to die with a pressure ulcer. And mortality in the hospital within this client group is up to 1 in 3, which is just staggering. If pressure care is something that you are new to, especially how that relates to postural care, we've done various webinars on that topic, usually around November time when the Stop the Pressure campaign happens. So if that's something you want access to, a bit more information on how we can support pressure care through seating, then just pop that in the chat function or reach out to us and we can share those webinars as well. And we've done some great joint webinars too, with tissue viability to get that comprehensive approach, holistic approach to pressure care. Another problem we can see are the structural changes that limit function. So when joints and soft tissues remain in these static, often flexed positions, like maybe fetal side lying for extended periods, they undergo these changes where we can see muscles shortening, ligaments and tendons lose their elasticity, and sadly sometimes we can see the joint capsules turning into contractures. Ideally what we want to be is proactive to stop these changes from happening, but there are some cases where we will come across individuals who either haven't received that support or have been lost to the system, or sadly they've been confined to bed without that intervention, and we can see these irreversible changes happening. Now, these adaptations, while protective in some ways, as I said, they can lead to these irreversible contractures, and we can see this typically at the hips and knees and ankles, and often at the shoulders as well. It is a common secondary complication that we can see with neurological impairments, but just be mindful that somebody doesn't have to have a neurological impairment to be at risk of developing joint limitations and contractures. If somebody is in a prolonged flex position, such as at night time, then we are going to get soft tissue shortening with or without that neurological element. Now, as I said, primary risk factor for contracture development is this immobility. And of course, then we've got spasticity, which is an added risk factor potentially for later development. So spasticity, are we talking about that velocity dependent hypertonicity? So it's just being mindful if you're working with individuals who are in these destructive positions for extended periods, but also have spasticity or that some neurological impairment. Just think about the great risk that they are at if we don't intervene and be proactive with that approach. Research has shown quite staggeringly that care home residents encounter joint contractures with a prevalence rate between 20 and 75%. I mean, 75% on the high end there, we're talking 3/4, 3 out of 4 individuals at risk of these joint limitations. But even on the lower end, 20% is still 20% too many when we think about how we can be proactive with this approach. One thing we need to be mindful of with I guess soft tissue shortening and sadly working our way up to those contractures is the increased risk of falling, making sure that transfers are safe, but it actually can challenge seating because of the critical angles that we need for sitting out. So hopefully when we go into the case studies, you can see the specialised support that comes from a chair like the Air Comfort. And yes, it's a compromise, but hopefully you can see how we can achieve an upright sitting posture out of bed for individuals who sadly even maybe get the term of being unseatable. We hate that term, but there is always going to be a solution. It may be a compromise and it may not be perfect, but we need to prioritise and define our seating objectives. And sometimes the key objective and the only objective is to simply get them out of bed. So there is a way around that. It might not be posturally perfect, but we can certainly accommodate and support within a chair like that, the Air Comfort, with that specialised support. And hopefully you'll see a bit more of that in action as we go through the practical element, where we maybe lack those critical angles for sitting. Okay. The effects of prolonged bed rest aren't only physical, they are profoundly psychological as well. And many individuals who are confined to bed experience this decline in mood. We can see reduced motivation and this loss of purpose, really. The absence of social interaction with friends, with family, with loved ones, reduced access to not only communal areas, but actually community activities. If we think about the use of some people's wheelchairs to be able to sit out safely and access the community, we can see this loneliness and emotional withdrawal happening. Critically, low mood leads to lower engagement in therapy and daily activity, which then creates this feedback loop where inactivity leads to low mood, which reduces motivation, which leads to more inactivity. So it's really important that we understand how to break that cycle, and that often starts with restoring safe access to upright seating. So it allows the individual to rejoin life outside the bed, outside of the four walls of their bedroom. Feelings of loneliness have this strong relationship with low personal well-being ratings, and research has shown actually that loneliness and isolation are twice as harmful as obesity is to physical and mental health. So if we think about the resources and the awareness that goes into that, shouldn't we be applying the same approach to getting somebody out of bed and getting them sitting upright? Those of you who, again, work within elderly care or work with the older person, those aged 80 and over are twice as likely to report feelings of loneliness. So that's why we need to put this emphasis on the psychosocial aspects as well. It's strange for a physio to say, but we're not just focusing on the physical here. It's actually about that whole holistic approach. So the solution. Now, the best defence against body shape distortion is movement and activity, and we can achieve this through a proactive, holistic postural care approach with which seated posture plays a role, but also that 24-hour element as well. So we still need to pay attention to positioning in lying, because it's believed that a lot of asymmetries start in lying and are then compounding in sitting. And by targeting that full 24-hour, by supporting individuals to have a regular change of position, we are hopefully best then maximising outcomes. So we'll get the most out of the chair and the best effects from a chair if we also pay attention to the bed and vice versa, but also all the other pieces of equipment like the wheelchair as well, and how that plays a role within that 24-hour approach. So addressing the risks begins by facilitating safe and supportive transitions from bed to upright sitting. And this is all about the role of seating in breaking this immobility cycle. It allows this clinical gateway to recovery and re-engagement. So instead of that vicious cycle, we have all these elements working together for improved quality of life instead. Now, remember, the mobility is not just a symptom, it's often the cause of cascading physical, emotional and functional decline. So that transition from lying in bed to upright sitting is a clinical turning point that signals the beginning of reactivation for the individual, not just physical, but also reactivation and restoration of their identity and living this meaningful, fulfilling life. So, as I've already highlighted, sitting upright improves respiratory mechanics, aids gastrointestinal function, enhances circulatory stability. So it makes individuals healthier and safer and more prepared to engage. But it's not only about the body, remember, it's by supporting someone in sitting, getting them out of bed, we're also waking up the mind. People become more alert, they become more curious and more capable of interaction and engagement when they go from that lying position to upright position. And that re-engagement then also restores a sense of control, and research has shown that motivation, that dedication to actively participate in their care actually improves clinical outcomes as well. So it's not only fantastic and immeasurable for the individual, but actually clinically for us, it can reduce the intensity of our interventions, the complexity, because we're getting a lot more active engagement and ultimately better outcomes. So we don't just sit people out, we're bringing them back to life and getting that fulfillment, which is ultimately why we choose to do what we do, right? With that holistic approach to improve their quality of life. So let's make the case for specialist seating first of all. Now, standard chairs are not designed to accommodate fixed deformities or any other joint limitations. Inadequate support can also lead to discomfort. We can see poor fatigue management and, of course, an increased risk of skin breakdown because the materials and the pressure redistribution elements aren't tailored to the individual. Inadequate arm support, non-adjustable angles, things like tilt in space and back angle recline, and poor stability can increase the risk of falls and injury and destructive positioning as well. So just as a tip, when I talk about interventions and the equipment that we can put in place, just remember that it's only as good as how the person is positioned within the chair. So a big part of postural care and something we can support with as well is the care planning element. So it's great to have the optimum prescription, but as clinicians we can't be there 24/7, so we have to pass that responsibility over, and we have to make sure that the care plan with photographs is clear and they are confident and competent to follow that long term to make sure we get that ongoing compliance. So the chair, we can maximize the chair by making sure that there's transfers and the positioning within the chair have that firm foundation to start with. So specialist seating then plays its role by allowing individuals who might otherwise lack the ability to achieve protective postures, whether that's through age, illness, disease or disability, to be able to sit out and have the significant impact on their health and well-being. I guess where it's different, where we talk, because we obviously have our standard range of specialist seating chairs that you may be familiar with, and this new chair is are very different because it's more of a specialised support. There's a particular need for this kind of chair setup, and it's about defining those seating objectives where postural care and support may not be the ultimate goal, but simply comfort and participation and sitting upright is. But we'll go through that in a bit more detail shortly. I won't go in too much about the chair because I think it'd be more beneficial for you to see it in action when Les runs through the chair so you can see the functions and accessories. But essentially what we're doing is supporting the individual, but also the caregiver network as well through a range of innovative features. And ultimately, moving individuals out of bed into an upright seated posture has numerous benefits, and hopefully counteracts all those negative things I've raised that span both physiological and psychological domains. So first and foremost, we of course have pressure redistribution and reducing the risk of skin breakdown. So we can see an improvement in tissue health. We can utilise functions like tilt in space to allow for load variation or even offloading of high risk areas. We can promote airflow and reduce humidity through the materials that you used. Some postural stability can help reduce friction and shear forces as well. And we can identify risk and be proactive, but we can also support individuals who already have existing pressure areas as well by having that frequent repositioning to support healing. We also have the support in the physiological health as well, so counteracting all those negative things we saw around respiratory distress and digestive issues and even those cardiac changes. What we hope to see by sitting upright is to restore the body's functional positioning, to enhance things like lung expansion, to improve that gaseous exchange, to allow clearance of secretions, which of course is critical for individuals at risk of things like pneumonia or those who are maybe unwell, and that's why they're confined to bed or they're recovering from an illness. We want to see circulation improve. We want to see the GI function improve so that they're maintaining nutrition, but also reducing the risk then of serious complications and hospital admission. But then I guess for us, this is where we place the most emphasis when we think about this client group and this particular chair and the specialised support that it offers. That top priority is going to be enabling someone to sit out of bed, to free themselves from the confinement of the four walls of their bedroom, but to do this comfortably and to make sure that we are meeting their well-being needs and getting this psychological uplift. So we can increase their sitting tolerance, we can encourage longer periods out of bed without this distress or fatigue happening. We can enable meaningful connection with others, this participation in meaningful daily life. But we can also improve alertness and mood and mental stimulation, which we know is key to recovery and rehabilitation and positive clinical outcomes. So breaking that immobility cycle. Now, our connection with the physical environment, especially in seated activities, has profound implications for our overall health and well-being. And if we get the appropriate support, we can give the individuals that we work with these opportunities for interaction with the world around them. We can also see improvements in self-confidence and positivity and engagement with others. So hopefully we're not seeing this vicious cycle of low mood leading to reduced motivation and engagement, which leads to further immobility and inactivity and then further worsens those complications. But there is a clinical compromise to be had with this specialised intervention. So it's important to clarify that it's not intended to fully correct complex postural presentations or provide long-term postural management. Instead, the priority is getting the individual out of bed, but to do that safely, comfortably and with dignity. The chair supports essential physiological functions like respiration, supports skin integrity, and allows for that vital psychosocial engagement to reduce the effects of isolation. Now, for many individuals, especially those who are frail or severely deconditioned, maybe someone who's recovering from an illness or a hospital admission, the goal isn't about perfect posture. It's about participation. So the Air Comfort Deluxe offers this safe and effective bridge that allows them to tolerate sitting upright and to engage in the world around them again. There are going to be specific circumstances or cases or individuals who are best suited to this kind of postural seating intervention. And it may be that other forms of standard chairs or even specialist seating within our range has been trialled. But ultimately, we need to define those goals, those realistic goals for sitting out. So there might be individuals who have been on prolonged bed rest, they have low sitting tolerance, they have issues with finding comfort. We may see emerging pressure risks, postural deformities. It may be within palliative support and end-of-life care, or even those who have this fear of falling or sitting out. It can be ideal for individuals, for frail individuals, or those recovering from illness who are not yet ready for fully postural, functional or rehab-focused seating. So maybe there's been some changes to the presentation and they can't utilise the equipment that they used to. So we can, rather than long-term support from the chair, we can utilise it as a short-term rehab and recovery as a bridge until they can start utilising more posturally supportive or functional seating. And just remember, it's best introduced through shared care planning. So thinking about nursing services, therapy, medical opinion, and even down to us as the equipment services or as the seating specialist. So the key takeaways then for rethinking the beds to chair transition, and hopefully, I know we don't have much time together during these webinars, but hopefully we've shared our enthusiasm around the importance of getting people out of bed and how critical it is for some of the individuals that we work with. So I'd like to think that you leave this session equipped with some more tools or some more knowledge to be able to advocate and raise awareness if you see individuals who have been confined to bed or who have, I hate this term, but who have sadly been deemed unseatable. And just remember that there are solutions. Yes, there'll be a compromise, but there are solutions as long as we prioritise and define seating objectives to getting them out. So prolonged confinement to bed is risky. It can lead to all these secondary complications like pressure injuries and physiological dysfunction, but also that social withdrawal as well. Sitting out is clinically transformative and we can help to restore a lot of these functions, but also support mood and participation as well. And then the Air Comfort Deluxe is available as a specialised intervention. Although not perfect, it is still a practical, critical compromise to reintroduce safe, upright sitting. So we thought it would be good now to kind of apply this to 2 case studies, just to really consolidate that and apply it to the seating solutions. So the first individual we have is Mary, who is an 89-year-old lady who resides in a care home. She had initially spent 2 weeks in bed after recovering from her 3rd fall, and there were already some elements of deconditioning and generalised weakness due to that. Standard armchairs were exacerbating her discomfort and actually increasing her fear of further falls due to feeling unstable. So sadly, that prolonged her confinement to bed to almost 2 months, as she was eventually refusing any transfers to the chair. So she, of course, was then in this immobility cycle. She was developing early stage pressure injuries because she was typically adopting this habitual fetal position inside lying along the right side of the hips and the knees and the foot and ankle complex. And as well as some soft tissue shortening changes happening as well at the hips and knees. So we'll show you, I can be a model and model Mary for you, but we'll show you in the chair what kind of things helped. And hopefully you'll see how we can apply an approach to define seating objectives, to specialised support, but yeah, clinically compromising, but ultimately needing to critically get somebody out of bed. And then the other individual we have is a 28-year-old male, so Stephen, who with spastic quadriplegic cerebral palsy, who had sadly been in hospitalisation for a few weeks due to pneumonia, and had therefore been confined to bed and experienced a marked decline in postural control and joint mobility, which meant that his much-loved wheelchair became unsuitable due to the not only the reduced sitting tolerance, but actually the changes in his lower limb presentation as well. He was really lacking that community access and engagement that he was used to, which was having an impact on his mood, of course, as a young male who was seeking that engagement with others. So the Air Comfort Deluxe then provided a therapeutic bridge back to function, so utilising the elements and some of the accessories to support his posture, and I guess to mimic orthotic seating for a period of time, being able to use the functions to start regaining some range within his lower limbs, so that ultimately he could get back out into his wheelchair and engaging with the world around him again. And hopefully we should be back on the screen now.
So I'm going to give you a little overview of the features of the Air chair, the Air Comfort. We've introduced this into the range as in recognition, if you like, of a niche within the specialist seating world that we didn't quite meet the need. So the Air Comfort is a tilt in space chair. Tilt in space being the back and seat angle remains constant, helping with pelvic stability. We also have back angle recline.
So that opens up the hip angles.
So if I show you how I was adjusting those, right hand lever on all Careflex chairs is tilt in space. So I just squeeze, adjust and release wherever is most appropriate for my client. Back angle recline on the left hand side, both are clearly labelled. Squeeze, adjust and release. The basis of the chair, or the foundation of the chair, is a series of 5 interlocking air cells, helping to redistribute pressure over a greater area. The fabric is a 4-way stretch breathable fabric, which gives you the benefit of the pressure care that's within the chair. You have an elevating leg rest, operated by a lever just on the side here. So squeeze the lever, just push that down. The foot plate doubles up as a channel leg rest as well. So I can just pop these up just to provide a little bit of support. I'll put them in a more conventional position there. I can increase the length or the depth of the foot plates to accommodate taller or shorter individuals. The chair has drop down side arms, just adjusting by a little toggle switch here, which I just pull out, drop those down. Do the same with the upper supports of the chair. As you can see, it's ideal for that side transfer off a bed.
Yeah, so you can see how we can really open up the hip angles to have that gradual reintroduction to upright sitting, especially where postural hypertension might be an issue, or even just, I guess, the proprioceptive sensory changes that might have happened due to being in prolonged lying. So we can gradually then, over a few days or a few weeks, gradually increase that sitting position.
And you'll notice as well, I'm not using an Allen key or a spanner. All the adjustments are tool free, because part of the design of the chair recognises the need to make things as easy as possible for carers to adjust and to use the chair. 4 braked casters, one of which is a single direction caster. So as you move the chair down a an even corridor. It stays in that nice midline. Other accessories for the chair, we can add a tray, and we use bolster cushions, which we'll demonstrate in a few seconds as part of the resolution for the case study.
Yeah. Come on and model.
So Rebecca's going to model
Yeah.
Mary.
So if you imagine, so just to recap with Mary, who had been in bed for prolonged periods of time, was habitually preferring to go into this right side lying position. We're starting to get soft tissue shortening. So you can imagine during hoisting, during transfers, that she kind of maintains that shape. So when we hoist down, what we might see is this wind sweeping happening because we're still kind of adopting that preferred posture. Gravity is affecting, and we go in and we see in the soft tissue happening at the hips and knees and being hoisted down into this position.
So I've used a little bit of tilt and space here to get gravity on our side, so the gravity's helping to keep Mary back in the chair.
Yeah, and just remember that we know there's a compromise. This isn't about correcting Mary. That's not a realistic goal at this point in time. The importance is to increase her sitting tolerance, to get her sat out again. But we can utilise different elements. So you'd hope that Mary has now been identified as someone of risk of significant postural deterioration, and her supine lying position is being addressed, even with simply something like a T-roll. We can
That's just a little bit of back angle incline for comfort.
Yeah, to open up the hip angle slightly. And we can use accessories then, like a bolster cushion, which is very similar to what you might see in nighttime positioning aids. And we can get that T-roll effect to try and separate the lifts, but also to get more of Mary in contact with the chair for that pressure care element as well. And hopefully what we'd see over time is we can start seeing some gradual improvements. Because one thing about postural stability is that it can affect tone, it can affect how somebody relaxes within the chair. So hopefully by offering that full body support and using gravity, as Les said, we can start seeing some lengthening and improvements in range to try and counteract that. We can also, if you're concerned about, the positioning that's happening at the trunk, there's a larger bolster cushion.
So I'm going to just bring away this top lateral just to give us a little bit more space.
And we can use the larger bolster cushion then to get some trunk support as well. On the right side, try and get more of an aligned position, but still have the support at the lower limbs. So again, getting as much contact with the chair as possible, accommodating what we can posturally, but remembering it's a compromise, and now Mary's actually out of bed and sat upright and can access communal areas and get that participation that she so needs.
Another neat feature of the chair is that if I go to put a sling on or off to get access, I can actually open up the side, so I can bring the sling down or remove the sling a little bit more easily
without affecting positioning too much. And the same approach then when we think about Stephen is utilising the chair to gradually increase that sitting tolerance, to reintroduce upright sitting, but ultimately we can start using leg rest elevation to try, because we're concerned, we know he used to have the range at the knees. We're hoping that the joint capsule hasn't been irreversibly changed, so we can start using it to stretch and to reposition with the aim of bridging that gap. So unlike Mary, where we may be seeing the chair use ongoing, we might see it more as a short-term approach where we can either transform and transfer to more standardised specialist seating, but ultimately to get it back in his wheelchair.
This is a niche product. Mm-hmm. In an ideal world, perhaps we'd love to set something more conventional product with more of a classic posture, if you like, 1990. But we're working with a client here who has an asymmetric posture, possibly a fixed posture, such as contractures or wind sweeping. Mm-hmm. Somebody who's stuck in bed, basically, and we want to get that transition, that bridge back out of bed into seating, into a more holistic environment for somebody.
Yeah. So it's just about defining your seating objectives. If we know that correction and with some accommodation of postural deformities is the goal, then we would be looking at a different type of chair. If we maybe thinking about involuntary movements or really erratic active movements, again, we might be looking at more specialised support, like the Alpha Care. Whereas if we are thinking our goal here is just a gradual reintroduction to sitting for someone who's been confined to a bed for prolonged periods of time and have sadly experienced some of these harmful changes like pressure injuries and soft tissue shortening, postural hypertension, then we need to go down the route of specialised support and interventions.
So that's the Air Comfort. I hope that's given you a little overview of what we can achieve with this product. As I said, it's not replacing any chair within the Careflex range. It's adding to the range, and we see it as a vital tool and a vital addition to the offering that we can provide people.
We no longer want to see unseatable individuals, so we no longer want to see that term accepted, and hopefully we can come up with some solution. It's just about defining those objectives, those realistic objectives. And being okay with some form of compromise as long as the individual is safe and comfortable. Yeah.
I think we'll take some questions if you have any, Kiwi.
Yes, we've got some questions. The first one is, what materials are used to assist with temperature regulation?
The 4-way stretch breathable fabric has the wick away body heat. So we'd be using, it's a product similar to Dartex, if you like. It's a 4-way stretch breathable fabric.
Yeah, and it allows contouring as well. So we offer some pressure care along with the breathability.
Yeah. Next.
Can this chair be contaminated so it can be used by more than one client?
Yeah, we can keep it. The chair can be stripped down. The covers are loose covers. I believe they're also antimicrobial, so that doesn't support the growth. I can't take the covers off now, but it's a relatively straightforward process to strip the chair back down to its base frame.
Yeah, and it can be wipeable as well with non-alcohol based wipes if you need a quick clean rather than kind of a full sterilisation. There'll be a fabric guide and cleaning guide along with this, so we could share that if we need to. Each of the chairs will have their own method of cleaning.
Anything else, Kiwi?
I've got, is this chair compatible with a Sarah Steady?
Yes, but it's not really the client that we would think first and foremost with the product.
Yeah, I guess it depends on the ability, whether as with any form of seating, with the ability of the client to actually position their pelvis at the back of the chair after that initial transfer, because other chairs, like there's a bit of a forward tilt on the multi-adjust that helps with that transfer. There's negative angle leg rest as well, but so you can get in a bit closer. There is low arms, so there's space for the paddle armrest, there's ground clearance, but it depends on it because there's obviously a lot of air support in the leg rest. It's just whether that individual can actually position their pelvis, if they got the strength to be able to. So it would definitely be worth a trial to make sure we can that transfer is still safe for them.
The issue is with the stand assist is that we can get somebody to cure, but we really depend on that person to do that. So it's
definitely worth a trial if you've got someone in mind to see whether that would. But there is, good ground clearance. There's low armrests.
Yeah, I didn't mention that we've got ground clearance for hoists from side and from front as well. Next,
I've got are the footrests removable from the chair?
Yes. So they're height adjustable, length adjustable as well, but quite an easy component to relieve from the chair.
Is there a negative leg rest angle?
No, not on this chair. Again, that's something, if we can achieve somebody, or if we can get somebody to sit in more of a midline posture, where we have the option to use a negative angle leg rest, we'd be looking at a chair similar to the the multi-adjustment where that gives you a negative -25-degree angle is standard.
Yes, that's why it's really important that what we said, to define those seating objectives, because if the main objective is to correct and fully accommodate contractures where we can get a good midline, potentially upright position, without then impacting on pressure care, but also if they have good seating tolerance already, if they're used to sitting upright, then as I said, you'll probably be looking at a different piece of equipment, even like a tailored solution where you can take the leg rest away and have like a hanging foot plate, so we can really accommodate those reduced knee angles. But yeah, I would definitely say that if that was a goal around postural management, then maybe we'd be looking. This would be kind of your postural care is further down the list. Your comfort and participation and actually just getting out of bed for health and safety is a key part, and that's why it's in the seating we're talking about water cell technology, and that's why this is air, because it's all encompassing and is there to I guess just accommodate as much as possible the position that they have, because there's either severe contractures or soft tissue shortening that we need to support in the chair, but ultimately it's a compromise because we just need to get them sat out.
Brilliant. I've got, how do you know they have short tissue shortening?
As part of the assessment process, whether there's joint, basically it just means that there's limitation in joint range of movement. So they have difficulty, generally it goes into a flex position, so they have difficulty extending the knees and hips out. And that would be part of your assessment techniques. Again, it's part of your assessment techniques to get an understanding of whether you think it's soft tissues that we can hopefully regain some function from, or whether we're starting, because there'll be a different end feel, or whether we start seeing joint and bony changes, in which case, sadly they can become irreversible. But that'll be part of your assessment, your hands-on objective assessment. And
it's an important thing for the seating assessor to know up front as well, because we know if we have full range of movement of the knee and full range of the hip, that's 90 at 90. We possibly may not be looking at this style of seating, and this is another reason what would bring us back here, perhaps more comfort orientated. If we've a full range, we'd be looking at something with more of a conventional leg rest and a foot plate with a negative angle if needed.
For this type of individual, you would likely be doing your assessment in their bed, because that's where they're confined to, and it would be a case of seeing how close we can get back to that anatomical supine position, midline position, and whether we can take the joints through all range of movement. But yeah, that would be the assessment techniques, the postural assessment that would be needed before deciding on the seating solution.
It's something, if you get the opportunity to come along to one of our road shows, it's something we go into quite a bit of depth on that objective and subjective assessment process.
I have another that says, how are individuals expected to be supported to get from bed to chair?
Typically with carer and assistance.
Yeah. So again, that will be down to the assessment, looking at the transfers, and working with the care team. I mean, it's obviously very different for individuals who live at home independently, because then I guess your seating objectives change again. Then. But yeah, this type of individual
would be fully hoisted.
Yeah, because they've been confined to bed for so long that they've been deconditioned. They have that generalised weakness. So it would typically be somebody who was hoisted across. Yeah.
Okay, I've got, what specification of pressure relief is the chair offering?
It's rated as high. So it's as I said, it's an interlocking air cell system, but it's rated as a high pressure.
5 different compartments.
Yeah.
Obviously, it has a whole seating system then, though. As Les said, the 4-way stretch, and how you utilise that in terms of tilt and space and postural stability, that all plays a part in it as well. And that regular change of position. So there's no piece of equipment out there that somebody can stay in for 10 hours in one position. We still need regular change of position.
I've got, is it my understanding that this is for short-term use until an individual is comfortable with sitting up and then can use more specialised seating or go back to their original seating?
Potentially, yeah.
Yeah, potentially, yeah. I think it depends again on the individual and how severely contracted, or whether those are fixed deformities, whether there's scope for recovery or scope for improving joint range of movement. I mean, if their position, sadly, they kind of been missed through the system and they've been confined for a very long time in this very tight, contracted, sadly bony changes, then this is likely going to be the long-term support for them, because there's no scope there to improve. So their presentation will be the same. It's just we're supporting them upright for as long as possible throughout the day. But if there's scope there, if you think that it's just soft tissue changes rather than bony changes, and we can start increasing range and getting somebody back to midline, then yeah, we would look to.
I guess the proactive approach to postural care in an ideal world was
to stop and get into that position.
Yeah, exactly.
In the first place, yeah, definitely.
I have one that says, if a patient has quite severe involuntary movements, would the sides be knocked off or accidentally hit while they're in the seating?
For this chair,
Yeah.
yes.
Yeah, so again, that would be a different kind of seating objective, in which case it would be something like the Alpha Care, which is designed for that type of individual. If it's somebody who has involuntary movements, if they're that active, then contractures aren't so much of a in terms of priorities, aren't the biggest concern, because they're so active and moving. That's protecting the body structure in itself. You'd hope that there was enough scope for positioning and postural support and stability in the chair, like the Alpha Care. Yeah.
Again, as I said, it's adding a chair to the range. We don't envisage somebody with severe involuntary movements like Huntington's stand transferring into a chair like this. It would definitely be the Alpha Care would be the first protocol for within our chair range.
I mean, we wish this kind of chair wasn't needed. So as I said, the ideal world, this kind of chair wouldn't be needed, because we would be proactive and stop people from getting into that position. But we know that people do get unwell. We know that people are hospitalised. We know that people are confined to bed for various reasons. And sadly, this kind of solution is needed, but it's a compromise.
The driver, if you like, for us including this within our range is seating assessments where we come away and we've not been able to offer a solution.
Yeah.
It's where that person's posture is so asymmetric.
And it just gets accepted that they're unseatable. Yeah.
The aim is to get them out of bed, to provide that bridge, if you like, as somebody said earlier on, hopefully to get somebody back into more standard seating or a wheelchair. Or
even just for palliative care, just for to get well-being and socialisation and aspects of increased mood for that period of time. This may be the only chair that they have access to be able to sit out and engage. Or it could be somebody who is sadly severely contracted, who has slipped through the net. And again, long-term, this could be their only supporting surface, but it means they get to leave their bedroom.
Okay, I have one last quick question. Is the chair height adjustable when it's flat?
No. Straight answer.
And
if you're looking at transferring, with bed, obviously be a high-low bed, so you bring the height of the bed down or slightly above the surface you're going to transfer into.
Yeah, you could find a way to do the transfers as safely as possible, but again, it depends on the individual. But as we said, this kind of injury is probably likely to be hoisted.
Yeah.
Brilliant. I've got also, are the arms height adjustable?
No. We can position the arms and slant those out, but they're not height adjustable. Again, it's all these features we cover within other chairs within our range.
Yeah.
The multi-adjusters, arm height adjustment as a negative angle leg rest, adjustable foot plate. It's a slightly different client group we're looking to address their needs for with this product.
Yeah, it's about having some freedom as well. You don't want it to be too rigid. You don't want the arms to be too high. You don't want it to be too rigid in its support, because it's all about comfort and allowing people the freedom to be able to relax into that position.
Because if somebody could sit in this chair with good sitting balance, I'm achieving 90 at the knee, 90 at the hip. I'm looking for foot support. I'm in the wrong chair.
Unless, of course, they find it comfortable.
Yeah,
That's subjectively what they're.
Yeah, that's the goal of the seating assessment. The objective is comfort.
Yeah.
Or skin
only
integrity.
pressure care. Yeah. Mhm.
Thank you.
Right.
I think that's everything.
If anyone does come up with any other questions, you'll get all our contact details anyway when we share the recording and the slides.
What's the email address, Kiwi? Is it info@ or training@?
It's a training at Careflex.
So if you have any questions, please feel free. What I would say is if you get the opportunity to come along to a roadshow, you'll find a list of the roadshows on our website, and come along and try the chair. It's a very deceptively accommodating and effective chair. It's a really useful tool to the seating assessor's kit.
Yeah.
If you'd like us to come out to you, we're more than happy to bring a chair out for you to have a little look at, a little try and a play with. Or if you've got a client you think may benefit from this kind of product, please let us know. And we'd love to come and see you.
Yeah. And try and kind of spread that awareness that we don't use the term unseatable, and hopefully we can come up with a solution. We just really have to define those seating objectives.
Yeah, it's bridging that gap, isn't it? It's that transitional product.
Yeah.
Okay, well, if that's it, then Kiwi, it just remains for us to thank you all for coming along.
Thank you very much.
Thanks for the Q&A session. It really put us on the spot and made us think. Hopefully we'll see you soon. If we don't see you before, we'll see you at the next webinar, which is in
May. Yeah.
In May.
Yeah.
Okay, thank you very much then.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.